for it.
Hello, everybody. Happy noontime wherever you happen to be. It's noon here Central Time at the University of Illinois in the Department of Communication, and very, very happy to bring you the second installment of Health Communication Barriers, Breakthroughs, and Best Practices, an online conference in health communication. And this is the first of 3 keynote presentations that are being streamed live and will be recorded for viewing later for your friends who may have missed it. We're really excited this year. We have over 600 people registered for the conference, which is well in advance of last year's presentation. We have almost 24 presentations in addition to that already stored on our website. So I'm very happy today to introduce our first keynote speaker. His name is Dr. Richard L. Street, Jr. He is Professor of Communication at Texas A&M University, and he's a very well-recognized expert in patient-provider communication. His work today, his presentation today is going to be taking us in the direction of what we know about the electronic health records and electronic health communication. I'd like to say a couple things about Rick. We've known each other for a long time. Rick has spent his entire career in Texas, but he considers himself a Midwesterner.
Sort of.
In any event, everybody that's here today are members of our health communication community at the University of Illinois. There's about a dozen of us who are going to be listening to Rick and talking to him. And online, you're welcome to send your comments. We have a moderator who will be fielding them. And when Rick's presentation is finished, she'll be passing on your questions and comments to him. So without any further delay, Professor Richard Street. Rick, thanks for being here today.
Great. Thank you very much, John. And thank all of you who are able to be here today to attend as our live audience, as well as those of you who are logging in online. It's certainly a pleasure to be here and talk a little bit about our work on how communication and information technology can or cannot enhance clinician-patient communication. Before I get started, let me mention that I have no conflicts of interest to disclose, and also let me give a couple of acknowledgments. First, to Xiaohai Zhang. He was a doctoral student of mine last year, and he graduated and is now at the National University of Singapore. And he is some of his work I'm going to showcase today, as well as some of his work that we've done together. As well as Neeraj Arora at Pecori and Ron Epstein at the University of Rochester Medical Center. These people have been really influential over the last 15 years or so in influencing my thinking about the relationship and the various pathways through which clinician-patient communication can contribute to improved health outcomes. So, if I were to ask you, why does good communication between doctors and patients matter, what would be some of the things that you might say? Some of the things you might say would be, well, doctors have to explain things in ways that patients understand. They can't use all of that jargon and stuff like that. And patients, they need to speak up. Let them know what's on their mind, tell the doctor that, and doctors need to be good listeners. And they ought to be able to talk together so that they come to agreement in order to decide on what to do to benefit the patient's health and well-being. You'd be absolutely right. But I consider communication to be much more fundamental and much more important to that. I consider it one of the 3 cornerstones of quality medical care. One is the science. What's the state of science as it relates to the diagnosis and treatment of disease? Competence. What's the technical competence of the people who are providing care? And what's the quality of the communication between clinicians and patients as they work through making decisions about actions to take to promote the patient's well-being? And in fact, I think communication is particularly important on what I have called and labeled the continuum of beneficence. All right, so beneficence, as you know, is a medical ethical principle. And you know, when doctors do their Hippocratic oath, you know, they take that pledge to do no harm. Personally, I wish they'd raise the bar a little bit higher than do no harm. I'd like for them to do a whole lot of good. So this is my continuum of beneficence. So at one end we have do no harm. That is, we need to avoid medical errors. And unfortunately, problems of communication often contribute to medical errors, either problems of misunderstanding between a clinician and a patient, or problems of communication and coordination among the clinical team. And in this middle area, I put the quality healthcare experiences, and that relates to the quality of the patient's experiences when they receive care. Are they getting the information that they need? Are they decisions being made, and are they part of them that they think that are in their best interest? And because they're sometimes sick, they may feel vulnerable, and are they being treated with respect and dignity, and does it appear as though people are committed to their well-being? Communication accomplishes a lot of those perceptions. But just because you have quality healthcare experiences doesn't mean you get any better. No, the gold standard for communication and its contributions to beneficence is whether or not it can lead to improved health outcomes. For that, then, we need a model. And so this is one that my colleagues and I developed about 9 years ago. Do the math, I can do that. That was published in the Journal of Patient Education and Counseling. Now, we've got our clinician-patient communication here, and we've got our health outcomes that we might be interested in. Any number of them we might be interested in. Survival, cure, remission, emotional well-being, pain management, functional ability, vitality, any number of health outcomes we might be interested in. If I come to you and I say, okay, I'm going to analyze the communication that is happening in these encounters, and I'm going to identify patterns of communication that predict these health outcomes, I'm assuming that there's a direct path between the clinician-patient communication and the health outcomes. That is not the way it works. You just don't talk and people get better. True, talk and some nonverbal responses like touch and hugs, they can reassure, they can comfort, and thus alleviate some like psychological distress, at least temporarily. But that's not the way the communication is going to work most of the time. Now, most of the time it's going to work through a more indirect or circuitous route where you hope that the conversation doctors and patients have accomplishes something immediately. The patient has an understanding of what's going on. They have an idea about what next steps are to be taken. The doctor has an understanding of the patient's perspective, their concerns, what their preferences are, what they want out of their care. They've built a relationship characterized by trust and rapport. They reach agreement on what to do in the next steps. The patient leaves that consultation with a sense of self-efficacy or confidence that they know what to do and what the next steps will be. And if you can accomplish that in the clinician-patient communication, then those proximal outcomes may contribute to some intermediate outcomes. I tell my students all the time, turn off your phone before you do any talks. All right, heal thyself. Okay. So you get some intermediate outcomes, like now the patient knows where to get access to the care they need, or now they know how to follow and can stay committed to a treatment plan. Maybe they know how to activate resources within their social network, and then maybe they develop self-care skills in terms of managing lifestyle or day-to-day problems that might happen in terms of the management of chronic disease. So if you can accomplish that, then that can lead to the outcomes of interest. So what we have here is we have our clinician-patient communication, we have our health outcomes that we're interested in. Clinicians and researchers, in my opinion, need to do more thinking about modeling the pathways through which communication leads to improved outcomes. What the communication does, it activates the processes or sequence of events or steps that will then lead to the outcome of interest. It's a simple analogy, but I look at it like dominoes when you set them up and knock them over. The first one you knock over is the communication one. It knocks over the next, and that final one it gets is to the improved health outcomes. And there's ways in which you can have the same pathway accomplish multiple outcomes, just like you can have different pathways to the same outcome. And I'll give you an example that's a little bit simplistic. I'm making it more simple than it is. But when you talk about hypertension control, we can talk about two pathways, medication and lifestyle change. So if we talk about medication, that conversation about what the medication options are, how to take it, how to manage side effects, that conversation is very different than a conversation about managing lifestyle, where you try to elicit what some realistic goals might be for managing diet or exercise. You develop an action plan for how you can do that. Very different conversations dealing with two different pathways to getting the same health outcome you might be interested in. So there's also so much work that we need to do about understanding what counts as good communication, because it may manifest itself in a lot of ways, just like bad communication can manifest itself in a lot of ways. But then also we need to do more work about what facilitates or interferes with that good communication. And that's where the technology comes in. So what I want to do today is talk a little bit about how technology affects the way doctors and patients communicate with one another, factors related to whether or not patients go online to communicate with their doctors, and whether or not that communication going online can contribute to improved health outcomes. All right, so let's talk about the way information technology can affect the communication between doctors and patients. And by that, I'm going to be talking about the electronic health record, or the electronic medical record. I'll use those interchangeably, EHR and EMR. In many ways, it's like another interactant in the consultation. While the doctor is in there visiting with the patient, they're also in there, working on that computer. They're typing information in there. They're responding to prompts. They're scrolling through tabs and screens and whatnot, and they're looking at a lot of the information in there. So the doctor is here interacting with his computer, and then they're interacting with the patient. So having this computer with the electronic medical record in there, what do we think? Friend or foe? Well, conventional wisdom would say it's not too good. Because it hurts patient-centered communication. Because the more time the doctor is focused on the computer and less on the patient, then that takes away from the time that they're giving to the patient. And indeed, some research supports that. More time using the EHR has been associated with less exploration of the patient's agenda. And what that means is what the patient wants to talk about. It's less conversation about psychosocial issues. And what psychosocial issues or conversations clinicians and patients may have with regard to how the patient's health affects their everyday well-being, quality of life as it relates to work, family, functioning, and those kinds of things. More gaze at the computer has been associated with less patient satisfaction, with lower observer ratings of the quality of the doctor's communication. And by that I mean when observers are watching a videotape of a doctor and patient talking. When the doctor spends proportionally more time looking at the computer than looking at the patient, it results in lower ratings and a poor understanding of patient concerns. Not too good. That's not a good sign at all. However, it's complicated because a lot of other research indicates otherwise. Either don't find that or just the opposite. For example, some studies have shown that working on the EHR has no relationship to patient satisfaction. And in fact, nowadays most people think that having the computer there is just part of what the doctor's job is. It's like the new normal. When you go in there, there's the computer and the medical record. And not only that, it can be a good thing. It has lots of information in there the doctor and the patient can use as they talk through things. And things the doctor and patient can talk about, they can enter it in there to keep a permanent record of things like that. It can actually facilitate biomedical information exchange, such as, we look at disease markers or other biomedical markers or pain and symptom management, medication issues and things that deal with more the biology of what's going on. Although, again, it may not help much in terms of how collecting psychosocial information. So whether it's good or bad in a consultation may depend on some things. And what most of the research is focused on is whether, to the extent it depends on the clinician's characteristics. So, for example, patients of more experienced clinicians, experienced in terms of doctoring or working with the EHR, those patients those doctors don't see the EHR as having much of an effect of what's going on, doesn't have much an effect on what they're doing in their consultation. But the patients of more inexperienced doctors see it more as something that has an effect that can be detrimental to their conversation. More communicatively skilled physicians actually use the EHR to facilitate the conversation with patients, whereas less communicatively skilled physicians tend to see it more as a liability with their efforts to have good communication with their patients. And then, of course, it may depend on the doctor's multitasking abilities. They're doing several things. What are their keyboard skills? Mine are terrible. That alone would make me a terrible doctor. Actually, there's probably 20 things that would make me a terrible doctor, and that's one of them. But they're working their keyboard. They're managing workflow in the system, and they're also conversing with the patient. So doctors who have better multitasking abilities are probably able to use EHR more easily and efficiently in terms of having good consultations. All right, so what we wanted to do, so I'll talk a little bit about some original research now. So what we wanted to do is extend this research in a couple of ways. And this was a paper that was published online either in October or November in the Journal of General Internal Medicine, and it'll come out in the print issue this April. But we wanted to extend this work in a couple of respects. First of all, we wanted to examine whether the different ways that doctors interacted with the computer affected the way patients communicated. There's been a lot of work on how doctor uses EHR and how it affects the doctor's communication and what people, patients or observers, think of doctors. Very little has looked at how it affects the patient's communication, and in particular the patient's active participation. And by that I mean asking questions, expressing concerns, stating preferences, introducing topics to talk about, making requests, things that put the patient's agenda and perspective into the conversational stream so that it can be addressed. We were interested in the effect on that and what we call the physician's partnering supportive communication. These are efforts to facilitate the patient's involvement. So like asking about their concerns, asking about topics they'd like to talk about, offering reassurance, encouragement, and things like that. So that's one thing we wanted to do, how it affects the patient's participation and the doctor's efforts to facilitate patient participation. We're also interested in whether the different ways that doctors interacted with the computer had differential effects on the communication. Remember, when you're interacting with the EHR, it's not either on or off. You're doing a lot of different things. Does the time you spent typing affect things differently than when you have more time typing versus less time? How about simply gazing at the computer? Or mouse clicks as you're clicking through, scrolling through different screens and tabs. Do these have, the amount of time spent on these activities, do they have differential effects? So this was an analysis of 217 audio-video, audio-video recordings and that are of primary care and specialty care medical visits. And so from the audio, we were able to get the, analyze the communication. And from the video, we could look at gaze patterns. And we also had an electronic system that could track how many keystrokes the doctor made during a particular consultation, how often they did mouse clicks in that consultation. Well, what we found is the only behavior that affected the degree of active patient participation was more keystrokes. The more doctors spent typing, the less active patients were. And so if you think about it a little bit, it makes some sense. Of the three, keystrokes, gaze, and mouse clicks, the most physically active is the keystrokes. You've got finger movements, may have some arm movements, and clearly patients may see that when doctors are doing that, they're busy doing something as they're doing their typing and all that kind of work, and they're very reluctant maybe to speak up at that point in time. Interestingly, gaze was not related to active patient participation per se, but it was related to the amount of mutual silence there was in the consultation when neither doctor nor patient was talking. So we looked at that a little bit more closely and found that in many instances, when the doctor was gazing at the computer, often they were not talking. Some patients in turn chose not to talk as well, creating the mutual silence period. Other patients, however, used the doctor's silence as an opportunity to talk a little bit more about some of the things they wanted to talk about and maybe introduce some more concerns. And interestingly, none of these behaviors, of these ways of interacting with the EHR affected the doctor's facilitative communication, in large part because of these other things we talked about, the doctor's experience, their communication skills, or their multitasking abilities. But before I leave this, let me also mention that there are some strategies, communication strategies people have suggested that clinicians can use to maintain, while they're working on the computer, to maintain the flow of the interaction as well as facilitate patient involvement. And one of those is just simply small talk. So they do social chit chat. They're on the, working on something and go, hey, so how's the weather or sports or something, or your family, I think last time you were here, you said your family and you were going to go on a vacation. How was that? So they fill in that, rather than have dead space, they fill it in with social chit chat. Other doctors actually use that as an opportunity to invite the patient to talk, so the doctor can work on stuff and they let the patient carry the conversational load, and give them an opportunity to introduce other issues or elaborate on issues. Any other concerns, how things have been going otherwise. Another thing some doctors use is signposting. And by signposting, what I'm doing is I'm telling you, the patient, what I'm doing on the computer. So I'm involving you in the conversation, but letting you know what work I'm doing. All right, so let me look at these lab figures here and see what we have going on. I'm talking, and I'm talking to you. Okay, or if you're entering data, say, okay, let me make a note of that. So you say these headaches come mostly at night. okay, let me make a note of that so we can put that in the record and we can follow up with it later. So that would be signposting. And it could even be used, although it's not used very often, but it can also be used for screen sharing, because charts and graphs and images in there can be very useful displays for patient education or shared decision-making purposes. Right, so what are our take-home points here? Well, using the electronic medical record in the consultation is neither good nor bad. It all depends on how it's used, for what purpose, how the doctor is able to manage the consultation, both the computer and the patient's ability to speak up and talk about things that is of concern to them. Although I think based upon some of our research, there could be some unintended consequences where certain types of activities, like a lot of typing, may have the unintended consequence of stifling the patient's participation in the consultation. All right, so now let's move from the electronic medical record and how that affects how doctors and patients talk about. And now let's talk about factors related to whether or not people go online to communicate and whether or not that can do any good. So increasingly, there are electronic means of communicating with doctors, and they just increase, it seems, every year, the different ways that you can do that. I remember back in the old days, because I've been working with doctors in their communication with patients for a long time, some of our progressive doctors had their business card, and they would give the business card to a patient, and that patient would have their email address on there. So if you use email here, just email me. And a lot of those email addresses were things like AOL.com. You know, it was a while ago. Nowadays, there's maybe less about email, but more of the same thing you accomplish through patient portals and secure web-based messaging and things like that, same kind of thing. But there are other options. There could be signing up for text messages, mobile apps, and other social media things, video conferencing. So if you can't have a conversation live face-to-face, you can have one live through a computer monitor, like FaceTiming people or something like that. All right, so if people are going to use the technology, and if it's going to do any good, that means we need another model. I like models, so we're going to talk about some of those. So this is one that my colleague Rajiv Ramal and I had developed about a little over 20 years ago. Gulp, how time flies. And I know because of the way it looks here, you may not be able to see it all, but basically it says if you're going to use online communication to improve health outcomes, it has to go through 3 different stages. So stage 1 is it's got to be utilized. So what kind of factors can influence whether or not the technology is utilized? Well, there are institutional factors. Do they perceive that there's a need? Are they willing to invest in it? Are they willing to train their employees in it? Then there could be technological factors, like what's the user interface? How easy is that to use? And what kinds of programs and services are offered? Is it little more than going into a portal and typing in a message and waiting 2 days to get a response? Or can you do other things as well? Are there options to sign up, as I said, for texting or for have mobile apps or different kinds of video conferencing or links to other resources and things like that? In addition to how responsive is the system in terms of when you're interacting, how long do you have to wait, and all. So all of those things are related to the technology. And then, of course, there could be user factors related to whether or not people think they can do it, whether or not they'll think it's do any good. Are they concerned about privacy of their information and things like that? So let's for a moment assume that all of these things come together to increase utilization. Then we move into this stage 2, which I label here as the user media message interaction. And what this refers to is when you're in the mediated environment of this computer screen and your keyboard doing that kind of interaction. All right? And so this really relates to really the quality of that experience. Are you in there? Are you able to accomplish some of the things you need? And some of those things you might need, is there a goal you want to accomplish, a need addressed? Is there some problem to solve? Are you trying to make a request? Do you need some clarification on something? Do you need some reassurance or support about something? So if whatever those needs are, if you're able to go in that mediated environment and have an interaction and be able to accomplish those things, then what the good things you accomplish from that interaction in stage 2 then carries over into stage 3. So when you walk away from the computer and you're on your other daily activities, you now know what to do to address the problem that you went online to talk about and therefore could help your health and well-being there. So now let's talk about this in terms of going online, factors related to going online to communicate with your doctors. And this was a paper that Xiao Hai and I published in Health Communication, the journal Health Communication, a year ago. And we looked at, we did an analysis of some of the measures that were captured in the Health Information National Trends Survey. That's hard to say. That's why it's easier to just say the HINTS survey. And the HINTS survey is one that the National Cancer Institute does every couple of years, and I think they've been doing it for a number of years, in which basically they're trying to assess the state of the American public's need for health information, health resources, the way that they get the information, what kind of media, what are their experiences been when they seek health care, what are their health conditions, what kind of support do they have in their social networks, and a variety of things like that. And one of the questions in the recent hints was, to what extent and in what ways do you go online to communicate with your healthcare providers? So the survey usually has several thousand people in it when they do it, but we focused only on those who had visited with a doctor over the past 12 months, and that was a little over 1,200. So when we looked at the variables, we put a model together like this. So we have our outcome over here that we're interested in, communication with doctors on the internet, using whatever variety of ways that they do it, and whatnot. And when we looked at the different variables, we thought there's a couple of personal factors that might affect whether or not people reported going online to communicate with their doctors. One was perceived health status. If I perceive myself in poorer health, I have greater need for healthcare services, maybe I'll be more likely to take advantage of multiple means of communicating with my healthcare provider. And the other was patient activation. And what patient activation is it refers to the degrees to which a patient is proactive in managing their health, structuring their environment to be healthier, managing lifestyle. When they go to the doctor, are they actively talking about things, asking questions, stating preferences? They want to be involved in decision making and things like that. We figured more activated patients would be more likely to take advantages to different ways to communicate with your doctor. And then we put another couple of variables in the media context, and here one of them was simply ease of internet access. And you might say, well, that's a duh, but for many of us, we take for granted that we have access to broadband internet, and like the people who are listening, who are watching live right now, but a lot of people have very restricted internet access, and what internet access they have is quite limited. So that would be one that we would think would affect whether or not people went online to communicate with their doctors, as well as their general behavior related to internet health information seeking. What that means is when I go to the internet to look up health information and get resources as it relates to my need or a family member's need or something like that. To the extent that I would go and look up information about health-related things on the internet, I would also be as inclined to go and take advantage of the internet to go interact with my healthcare providers. All right, now, those things alone we predict are going to have effects on whether or not people went online. But what we've got to realize is all of this is embedded within the context of clinician-patient relationships. And the quality of those relationships and the experiences with those relationships may strengthen or weaken these effects. So they had a couple of variables in the survey that we could use to see if these effects were moderated or they strengthened or weakened the effects of these that we think are going to be predictors. One was patient trust. And you would think that the more patients have trust in their healthcare providers, it would strengthen the effects of those tendencies of wanting of these personal and media factors to go in and communicate with the doctors online. Less trust, it may dampen or weaken that effect. And the other was, what has been the quality of their communication experiences? How patient-centered have they been when they normally have gone to interact with their healthcare providers? We would think that people that have had more positive kinds of experiences it would strengthen the effects of personal needs and media-related factors that might affect going online, just like poorer experiences might weaken those. All right, so what did we find here? Well, in terms of personal factors, patient activation did predict going online, people reporting going online to communicate with their doctors, and this effect was strengthened when patients also reported more trust in their healthcare providers. Perceived health status alone did not predict going online, except for those patients who also reported having more trust in their healthcare providers. In terms of the media factors, indeed, ease of internet access predicted online doctor-patient communication. And in the past, internet health information seeking in and of itself did not, except for those patients who reported having had more positive patient-centered communication experiences with their healthcare providers. And this one is actually kind of an easy one to explain. I may be going online to get information and resources because I'm not getting it as much as I need from my healthcare providers. So I use this as a substitute to talking to my healthcare providers. On the other hand, if I go online to get health information and my experiences with my doctors have all been patient-centered and positive, then if I go online for health information, I might as well go online to communicate with my doctors. All right, so what are our take-home points here? Well, personal level, there are going to be some drivers of actions related to wanting to take advantage of online options to communicate with your doctors. And this will need to be provided the opportunity and experience to be able to do that. But I think the important thing is, especially when we kind of wrap up, include in here elements of the chronic care model in this last point, is that for all of these things to work, in order to have productive interactions among engaged patients and patient-centered clinicians, it needs to be within healthcare systems that can support these interactions through the offering of technological and information resources to help doctors and patients accomplish the things that they need to do in their medical consultations. All right. Now, if you go online, will it do any good? And for that, I'm going to talk about some of Xiaohai's work. And this is part of his dissertation. And this part was a paper that he did at the International Communication Association Conference last year. So basically, he took the three-stage model. We've already seen that. And he was interested in, this was a survey of people in China, national survey of Chinese respondents. And he was interested in what the pathway through which going online could contribute at least to perceptions of better health and well-being. All right, so he used kind of like a model, like planned behavior kinds of models, kinds of health behavior models. And what those models are is where you're looking at what predicts an individual taking action in a certain way. So that action would be going online to communicate with your doctor. So what things would predict that? Well, self-efficacy or the confidence I could do it, behavioral capability, do I have the capacity, do I think anything good will come out of it? That would be outcome expectation. And then would be, am I aware that I could even do it? So that would predict whether or not people went online to communicate with their doctor. Now what he argued is that if they go online to communicate with the doctor, that will likely enhance patient satisfaction. And his argument was this way: if I go online to communicate with my doctor, I'm getting access to some healthcare services that I wouldn't have gotten to otherwise had I not gone online. And he assumed that that might tend to have generally a positive effect. Right? So if I go online, I probably can come out being happier with my care. But that would be affected, strengthened or weakened by the experience of when I did go online. How was it? Was it cumbersome? Was there too much a delay of response? Did I get my needs met or something? And then going online, and then if a patient was more satisfied, that would predict better. I'll just focus on emotional health and physical health. Because it could be the therapeutic value of being satisfied with your care. So if you feel like you've gotten good care, you may think better about your health and well-being subsequently. Or you're more satisfied with your care because you got some things taken care of. So there's actually biological reasons why you might be in better health and have a better emotional and physical health. So now I've got to put this in a little context here. So what Xiaohai did is that this was a panel survey. And he had time 1, and that was the baseline. He had all of those variables in that time 1 survey, all of these. And then at time 2, which was 1 month later, he included some of the same variables, including patient satisfaction. And at time 3, he did another survey 3 months after time 2, and it had some of the same variables as well, including the health outcome variables. So as you can see from the way this is laid out, this kind of follows like a longitudinal step. I go online, something good happens, I'm happy with my care, and now I'm satisfied with have perceived myself as being in better health. Well, this was a cross-sectional survey, so they all filled this out at one point in time. So For a person to make an argument that this is the relationship among these variables, they have to get their model, put their model together, and then test that against competing models, such as, well, maybe because people are in good health, that means they're satisfied with their care. So you put this against competing models, and when he did that, his model had the best fit. Fine, I think that's okay. I'm not really into statistical gymnastics like this. I'm really interested in can you identify longitudinally a timeline in which something happened that led to something that led to something else. And so I asked him about that, and so then he told me, these are not published yet, and so he just went and told me and reported to me what some of these relationships were. So, in terms of the time 1 to 2 to 3 surveys, at time 1, what factors predicted online patient-provider communication? Well, self-efficacy, behavioral capacity, outcome expectation, all did, not surprisingly, but awareness, simply being aware that you could, did not. All right, so what predicted satisfaction at time 2? Well, indeed, greater use of online communication reported at time 2 was also predictive of patient satisfaction 1 month later. So, what then predicted perceptions of health and well-being, or physical and emotional health, at time 3? So, online communication at time 1 did not predict these outcomes at the time 3 survey. However, patient satisfaction at time 2 did predict better physical health 3 months later, and even though it wasn't significant, there was the same trend for better emotional health. So we have at least a little bit of a kernel of what a pathway would be between where you can think about going online, can accomplish these things, and you're more satisfied with your care. That can lead to sense of feeling that you're in better health later on. So there's so much work to be done with that, but it offers a lot of possibilities, and this is a great first step. So, what are our take-home points here? Well, ways in which online clinician-patient communication can contribute to health outcomes, it's a work in progress. There are so many opportunities for this because increasingly we're going to have ways of multiple ways of interacting online with healthcare providers. And what's interesting about this, as opposed to face-to-face, is we can also take into account elements of the media through which we do this, like the media richness that may come into play. So, for example, if we're going to talk about different pathways that relate to media richness and interactivity, a communication pathway relying heavily on information, such as taking medication appropriately or addressing a particular side effect, could be accomplished through just simple verbal exchanges that you might be able to have, like email or web-based messaging or texting or something like that. There wouldn't necessarily need to be a lot of interaction, and it would be mostly informational, and you could possibly address that. Now, on the other hand, if you are to need a pathway that needs more interactive, iterative turn-taking, where we have to talk about things back and forth, well, we're going to need a more responsive medium, and perhaps one that's a little bit more sensory rich. So it might be something that we might have live chat for that, or telephone calls, or video conferencing for those kinds of things. And then what if we have a pathway that deals with managing emotional distress? Well, in those circumstances, we'd probably require a very rich medium to be able to have both the exchange of verbal and nonverbal behavior in ways that in real time, and the option that you would have that would be something comparable to video conferencing. So, those are some take-home points about how the technology can affect the way doctors and patients communicate with one another, that factors related to whether or not people go online, and at least the skeleton, a start of how online communication may actually lead to a sequence of things that could contribute to health outcomes. So we've got our references here, and now I think we're open to questions.
Just starting down the list here, we just had a comment from Carrie Stevens saying signposting when typing in the EHR is interesting. We have found that nurses do this very well, especially when using their mobile devices in front of patients. And then Claudia Montero said, great presentation. One question, usually doctors believe they just need to manage basic communication skills. How could you trigger doctors value more their communication experience? Maybe she meant to value their communication experience more.
Like to place more importance on it? Well, That's a difficult question to answer, because are we making an inference about the value they place on communication skill based upon something that we think they don't value it, or the perception that the way they interacted with us doesn't appear as though they valued it? So I think that is part of the answer, I think, because the things that tend to lead to clinicians developing better skills tend to be associated with most kinds of skill learning. All right? They have to perceive that there's a need, so somebody needs to emphasize how important this kind of thing is. And then there needs to be some instructional capacity, particularly related to feedback. And the two types of feedback would be people who you're interacting with, like standardized patients or other kinds of folks, or even reflecting on how you look in a video doing these consultations. I don't know about y'all, but watching yourself on a video, it's a very humbling experience. I'm dreading looking at this at a later date. No. So it's that kind of thing. So I guess the quick answer to that is that it's, I think, perceived importance. A lot of times if people see something as important, they then take steps to be able to do things that are important, but put it within an instructional medium that can take advantage of those kinds of things, like role-playing and feedback.
Other questions or comments from our local audience?
Yeah, Rick, thank you for a really strong presentation. Certainly I think technology is here, and I'm curious about just how patients of different ages feel about technology, whether it's the electronic health records or going online to communicate with providers. When you present your models, have you or any of your associates, have you looked at differences in those paths from, like, say, mature adult, over 55, 60, compared to, say, a younger adult? I mean, are you seeing any differences for preferences of how they use technology?
So, not deliberately.
Excuse me, Rick, can you just summarize the question?
Oh, okay.
The online audience.
That's right. Okay, good. Thanks for bringing that to my attention. So the question is, are there any, when talking about these pathways and the preferences for technology, are there any age-related differences with regard to these preferences and what good that they can accomplish? Is that good enough? Okay. So I've got two answers to that. One of them is that most of the work we've done on pathways have been within a particular clinical context. So if we're talking advanced cancer, it's people that, regardless of their age, the big thing they have is advanced cancer. If we're talking about people that have problems with osteoarthritis or something like that, so you will deal with those people. And so many of those are middle age to older. So we haven't had in our studies looked at many that would at least apply to younger people. We haven't really found much in the way of age differences among these clinical contexts that we've looked at. Now again, we haven't looked at it on the electronic side. We've simply looked at it on the face-to-face and pathway side. However, having breakfast with the graduate students today, one of the ones that talked to me said, as we were talking about some technology, said they were glad that they could get their partner who had an infection here, and thus they were out of their range, and their healthcare provider in the system was in California. And so they were able to go online, a young person, were able to go online to do FaceTime to address that particular infection and need, and it got it taken care of. And not only that, the thing that really hit home that makes this pertinent to your question is that student also followed up by saying, and he would never go to the doctor anyway because he really hates doing that. But he'll FaceTime with anybody. So that could be something that might be something that is worth following up on. That's one anecdote, but that stuck with me as something that, none of us like to go to the doctors. I mean, maybe some of us would rather FaceTime with their doctors. They can't touch us as much, I'll FaceTime, even with the touch screen, so to speak. So anyway, okay, good. Yes?
Thank you so much for all of your thoughts on this and your research. I'm wondering, from a practitioner standpoint, what should we be telling doctors? And what should we be telling engineers who are building these technologies about, what is going to make it most effective? So when I go to my doctor, sometimes she has an iPad. And that's like huge in terms of our ability to interact because it's mobile, right?
Mm-hmm.
So it just got me thinking about, what could we recommending for building the technology, and what can we be telling the doctors about how to do these things more effectively with patients?
Okay, the question is about how can we make doctors more aware and educate them about the various ways that the technology can be used to meet patients' needs and expectations and preferences, and how we would go about building that. Is that fair? Okay. Well, the people who do this successfully, I mean, they've got their model. They got to get their end users involved with regard to how they talk about these kinds of things and all. The problem is that you're going to have some doctors. It's like when I mentioned about the old giving out your business card with the AOL.com, you know, back in the old days, and you know these were the progressive doctors. So you have some like the one you were talking about who has her iPad out and does a number of things like that. So part of the resistance you're going to have is that doctors will need to know about is what patients become more aware of what patients would like to see in these kinds of things. It's like when I do interventions to improve communication, I focus on the patient, because usually the patient's problem is not speaking up. So we can do an intervention, education, activation thing and get them to speak up. Doctors are different because they have so many consultations. They develop this style of communicating with their doctors, and it has certain elements and components to it. And for many of them, it does not involve the technology. You know, it's like teachers. You know, all these teachers say, I'm going to always lecture to the large class and, you know, do all of that kind of stuff. So they've got these habits that need to be broken. And so having some feedback from patients in terms of what those preferences are would be helpful. And the other thing is keep it simple. So you're going to have a lot of patients, especially if they're younger and whatnot, that'll be very adept at all sorts of things with regard to technology. A lot of doctors that don't use it, they're going to need it to be really simple kinds of things. And some of the technology people, they're so into what all the technology can do. You know, it's like every time we get a new iPhone, I mean, I stress. Because, you know, it's like, oh my God, they got all these different things now I have to do. Why don't we just keep it simple? And so that would be something that would be part of what the end users would provide, the developers of that kind of feedback, that would be important. So, and that's not really a terribly good answer, but I think the main thing there is to get doctors to do it. A lot of them have to change the way they normally do things and think about it differently.
We have a couple more online questions here from Haley Huckabee. Are there things we can do on the design side that would help facilitate better interactions, specifically for the live interactions during a consultation?
So I have looked at, on the design, have looked at how the different ways of interacting with the EHR affects the communication. There's been other work that people who look at managing workflow in the EHR, they focus on cognitive demands on clinicians and the other kinds of stressors that they have, and they work through all of the things. I am not as familiar with that information, but when we've done projects in certain grant groups that I've worked with, we had teams that kind of were interested in those kinds of things, and our team was a communication team. They were interested in those kinds of things. And the only thing I can share there is that doctors have a lot of complaints about how not user-friendly electronic medical record systems are. And so I cannot answer that question in terms of what are the design things. But I know that there are a lot of suggestions of what a lot of people would like to have happen. So I apologize that I don't know enough more to ask about that question and to answer that question.
We have another one. Ooh, I'll butcher her name. Suleiman Koulibaly. How do physicians feel when patients come to clinics with information gathered online? Sometimes information is even contradictory. Do they educate patients about quality of online information, and how?
So there's been a longitudinal trend in this regard over the last number of years. At first, it used to be a threat. You know, here I come in with my pages and my printouts and stuff like that, and so I know here's the stuff I found, and so what, you know, you're no longer the expert doctor. You're one of multiple experts, and I've got some information here, and it's kind of counter all of these other things. So there was initially kind of a fear of threat, but that's been a while ago. I think nowadays one of the things that many doctors like about the patients that go online and look at stuff, that's an engaged patient. They can work with an engaged patient. They can talk about through these things. They know what's on their mind. And so a lot of doctors see that as a good sign about a patient caring enough about a health-related issue that they are then out there trying to get out information so that they can come and they're going to the consultation to talk to the doctor about these kinds of things. So that's a positive thing. True, you can take anything to extreme. You can go and just say, well, you're completely wrong, and everybody has that student, that patient, that somebody that kind of stands out in that regard. But I think if I'm recalling some of that evidence correctly, and if I think about the doctors that I work with and some of the things that they talk about, being threatened by people going on the internet is not an issue anymore because it's also not new. People do that a lot. And the positive side they take out of it, it talks about a level of engagement, which is oftentimes a complaint that some doctors have, is that patients don't care. At least one that's gone online to look up at a lot of stuff cares. You can work with somebody that cares in terms of trying to work through things. So I think that would probably be, more people would say it's a positive sign than it ends up being a threat.
I've got a couple of questions, actually. Once again, thanks very much, Rick.
Okay.
It's a great way to start the conference. I have several questions, but the first one I wanted to ask had to do with the first study that you talked about, which I admired greatly. If I recall correctly, a couple of hundred recorded interactions. Nice. I love that, you know. I don't know how you climbed over the HIPAA transom to gather all of that, but I admire you for it. We've been studying the use of medical scribes, which adds a body to the room and an interactant to that triad that you kind of led us toward, the physician, the patient, and the EHR. Have you any experience observing scribes assisting physicians with EHRs, or would you speculate on what that would do to your set of observations if we added the scribe in there?
So so we can look at it in a couple of ways. Okay, so let's start with and I'm going to do this kind of conceptually. Oh, the question is there any work that's been done where you look at how scribes may influence the nature of the communication in the consultation? So when we think that we have a doctor and a patient, interacting with one another, we have a dyad there, we have two. But lots of interactions, lots of consultations don't have two people. They have somebody else in there. Oftentimes it's a family member or they're accompanied. Okay, so when a doctor is talking to a patient who's accompanied, well, it all depends on what the person who's accompanying them does. So, for example, we have a lot of conversations, and we've seen lots of these, where you'll have a conversation and this wife or spouse or daughter or somebody, they don't do any talking, they just sit there. And then sometimes the doctor may make eye contact to the person, but it ends up being nothing. They just end up having their conversation with one another. Move something comparable in terms of a third party. That is, lots of times doctors will have a medical student who will sit back and observe. And so here you are talking, and pretty soon it's like having a video monitor in there. It's kind of like, just in the background there, because it's nothing's happening in there unless they're taking some actions. So then they have the medical student there, and that student is just observing. So then if you have the scribe in there, so the scribe is taking notes and things like that, is the scribe just in the background taking those notes, then there's the scribe just taking the notes. But what then starts happening when you then have the person who's accompanied them start having some conversation with the doctor, where you have a medical student where a doctor starts asking them questions about what's going on, because part of an educational element of things, or the doctor starts talking to the scribe about things to write down. And so that then influences the nature of the interaction to where now you go from like the doctor and patient together to like 4 different scenarios of what could be happening there. So the thing then becomes, from a patient's point of view, so having a companion there, now we can move that one off to the side, but here I am visiting with the doctor, and the doctor spends time interacting with the computer, and do I think that's a good thing? They're not interacting with me when they're working on the computer necessarily. Are they spending time interacting with the scribe? So what am I supposed to do? Just sit here and watch them do their thing if they're talking to them? Or if you have the medical student, they're doing the same kind of thing, doing some training there and whatnot. So what's my perspective on, are we taking my time to have you do these things? Or is it just part of, it's kind of inconsequential because it's just activity that doesn't last very long and it's okay. I don't know if that answered your question, but I think the more important thing is it's not so much the role of the scribe, a person in the scribe role, as much as that there's another interactant in the room and what are they doing. And the more silent that interactant is, the less likely they are to then become a presence in affecting the nature of the consultation. Is that okay enough? Now, I do know this sometimes. I've seen doctors and worked with some doctors that had the medical student in the room and the same doctor that didn't. Well, sometimes when they've got the medical student in the room, we're in performance mode, because they've got an observer there, so they're sitting there, kind of, yay, they're doing a lot more of that kind of stuff because they've got somebody observer. So you can have kind of those observer effects. So I don't know if that answers your question or not, but that's what I would say about scribes. So the answer is no, but we have looked a lot with work with companions when accompanied visits. And in some of the consultations we'll have like a medical student, or sometimes there'll be the resident and then the attending has to come in and things like that. So given your nonverbal reaction, I'm not sure I answered that question.
Thank you. And it's a little bit of a disingenuous question because at the other end of the table there's someone who's studied scribes, several hundred observations of scribe assisted physician-patient interactions, and a medical scribe somewhere down there as well. So I was thinking about it really somewhat in theoretical terms, and you've hinted at a couple of places that we might position this. One is how much does the physician interact with the scribe in the presence of the patient? That's something. And then you also used the term silence a couple of times. If that person is silent, then from some interactional point of view, just trying to abstract from the immediate event a little bit, we have less of an influence, right? How does that square with the observations that you've done at the other end of the table?
Good question.
Is the silence simply take care of the business of the scribe's presence in the room in terms of influencing the interaction?
That depends. I've seen some scribes are more involved than others, and I have seen physicians change how they interact with the patient to make sure that the scribe is recording things that they need the scribe to say, which may also be a change that they would do with an EHR anyway, that they have to change their communication to respond to what's on the screen. But they've also been very aware that they are speaking for somebody else, even if that person is supposed to be ignored by the patient to some extent. And so the silence too might be less with a physician, but there's still typing in the background that the scribe is doing. And so it's still, the sounds are still there, it's just not the physician physically moving.
Right.
Which sometimes too you can see patients respond to that, where they'll pause and wait for the typing to stop before continuing even though the physician is just in front of them.
So what's happening is the doctor is talking in a way to help the scribe type the information in.
And it's not always obvious.
Okay, but sometimes it is obvious because it affects kind of the spontaneity of the conversation. So what I see comparable to that is what I've seen in some instances where they use the recorder and they talk into the recorder in a certain way to capture the information, what they want to say, and you're not part of that conversation. You're just talking into the recorder for what it is that you're going to say. A patient says that they're this and this kind of thing. It's like, here I am, and I'm talking into the recorder, I'm not talking to the patient. So I can see the scribe being kind of a similar kind of thing, and thus being, I don't know, in the work that y'all did with scribes, did you look at what people thought about having them in there?
No, getting patient information was one step farther than our iron.
So is this accurate to say though? Because when we see accompanied visits, what we, in a way, like if you have a husband, a wife, and a doctor, let's say, you could have, see if you have two patients, there's just one interaction. So you can have doctor to patient, doctor to wife, wife to husband, and group interaction. So you could have 4. But almost always, when we have accompanied visits, the other end of a turn exchange, no matter who the turn exchange is involved, it always involves the doctor. The doctor is talking to the patient, the doctor is talking to the companion. Doctor is talking to the scribe, doctor is talking to the medical student. And there's not a lot of that cross thing. In fact, some of the more interesting things you often hear is like when the doctor goes out of the room and they've left the recorder on, like have a patient and their companion talk to one another about what's going on, and it's being picked up on the thing. It's really interesting, some of the things that people will say. So I would think that if that's the way that it would work, then I'm not sure how that ends up being anything other than patients may see that as not enough time for them, depending on how much time they are spending on it. So, but you have more observations of things like that. You know, we just have what we normally see and have to account for communication-wise is when the patient brings a companion in. And what's their role? Nothing? Do they tag team? Does this companion then is really the surrogate communicator, you know, for a patient?
We have another online question from Sharissa. How do clinicians get patients to buy online healthcare access in this age of massive data hacks? I have found that more parents are refusing to input information online with Equifax hack, etc.
Well, so how do the question is how? Oh, I guess they probably heard the question.
Can see it in
Oh, they can see it from you. Okay, good. Well, I wish I had an answer to that. I know that's a problem. I do know this. It's like this is not often a conversation that I've overheard, and I've heard some pediatric conversations in consultations before. We've done a number of studies in pediatrics. That's not a conversational topic I've seen discussed, and it's not something that I've am familiar with outside of the consultation. It's kind of like also cost. You know, people don't talk about cost very much in a medical consultation. So, sorry about that.
I've got one more.
Okay.
In that last study that you were just discussing briefly, Yang,
Zhang?
the paper that was presented at ICA in San Diego last year, did I get the impression then? Actually, 2 questions. One, was health status controlled for in the very beginning throughout this? So was patients' health status held constant?
I'm not exactly sure, but it should have been, because it would be a covariate from time 1 to time 2.
Right.
Yeah,
And then,
yeah.
But then in the outcome, it sounded like satisfaction winds up being a health outcome. Is that, did I understand that correctly? Well, you might go back to that very last, it's not far back, because it was before your well, but no, it was the bottom bullet, right here. Patient satisfaction at time 2 did predict better physical health at 3 months.
So satisfaction.
Satisfaction at time 2 seems to have a causal effect on physical health at time 3?
Well, so I'm gonna. It could have an effect, because what we're dealing with is a perception, like an affective reaction that's affecting a perception of the quality of your health. So we're dealing with cognitive variables here.
Yeah.
So I'm going to give you another example that's not related to this, that talks about the therapeutic example of patient satisfaction. Okay? And so this would be one in which we did model a pathway in acupuncture for people with osteoarthritis of the knee. And so what we had was we communicated in that randomized controlled trial 2 different communication styles. Neutral, well, this sometimes works for people, sometimes it doesn't. We'll just have to wait and see. That's what the acupuncturist communicated. And then in the other example, I'm hopeful. You know, we've had some success with this, so it's a real optimistic thing that you're doing. Anyway, so those two, then they have their interaction. They do their course of acupuncture. And then later on, at about 2 months, they then ask patients how satisfied they were with their care. And this was where there's both sham and real, and you know, that didn't have any effect. And the patients that had the more optimistic healthcare provider reported being more satisfied with the course of their treatment than did the patients that had the more neutral person. And then the satisfaction with the treatment then predicted people reporting they had better functional ability 3 months later. So what we're talking about there, the argument is there's a therapeutic value to thinking good about your care. And particularly if you're going to use a self-report on your health and well-being, that your affective state, based upon whatever it is, the care that I got, can maybe influence how you interpret what your experience is dealing with a particular condition. So that's the logic. So it's not like a placebo effect per se. I mean, it kind of has a lot of similarities. The placebo effect would be whether or not sham produced a good result compared to the real. That would be the placebo effect. And the mechanism, by the way, may be the effect that it may have on the attitude that I have about treatment. But I tell you what, when I report better functioning of my knee after a treatment, who is to say that I'm not having better functioning of my knee? You ask me if my functioning is better, and I said it is. And what variable can account for that? People being satisfied. You know, acupuncture is a good thing. I'm happy with it, and I feel great now. Now you're kind of going to be skeptical, and I'm that way too, and everything.
Actually, I mean, you early on you made that observation. The gold standard for health communication research is better outcomes, right? This is what we want. We want to show that communication has an effect on those health outcomes, including things like, I suppose perceived physical health. So
yeah.
hello.
Yeah, well, see if we go, and again, I've got a number of slides here, but see if we go back to this continuum of beneficence thingy.
Yeah.
See, I would put satisfaction in that quality healthcare experience part. Doesn't mean that these are separate from one another. Where am I? Here. No. Sorry, it's going back. Sorry, I have to do all this. Where I would put satisfaction would be part of that experience of right here. That would be where patient satisfaction. These are just categories. These are categories. Now, I'm saying these don't necessarily contribute to these, but they could contribute to those. But I'm just saying I'm not going to stop right there unless I have to, because I can't follow up any longer. I'd rather stay focused and see how far I could go over here.
We have another one online here. What is your opinion on using technology as a tool to prepare patients for consultations, and how do you think this may affect doctor-patient communication during consultations?
So that's a really good question because it's one that I know something about. So it's good to have a question that I know something about. So one of the things that is a pretty common technique to engage patients more in consultations, in shared decision making, make them be more active, is they have a pre-consultation intervention. And that pre-consultation intervention is often through some sort of technology that they do, where they go and they fill out something, they write down some questions, or they go through a little program that talks about the importance of what they need to do. Why don't you write some things down? And it leads them through there. And it's all designed to get them to activate, get them to say things, so you have something to talk about, so that you have, you've made some notes about what you want to talk about. It's okay, and doctor wants to hear what you want to talk about. And a lot of those are delivered, like participating in shared decision making, a lot of those are delivered prior to the consultation. And the ones that deal with shared decision making, they also have things where they sometimes go through advantages and disadvantages, and so they lay them out, so they try to educate the patient about advantages and disadvantages before they then go in and visit with the doctors. So treatment for early breast cancer is a great example, because we have two options. We can do breast conservation or we can do breast removal. And then all of those, and so there's advantages and disadvantages. So you have some in which the technology is what the patients are using to learn and to help activate them to be more involved in that decision making. And that is a very good resource, because once you have that technology, you don't need human resources to do that kind of education. So in that regard, it is really good. Other people used, like with CD-ROMs, when it used to be CD-ROMs, now with websites and stuff, they use a lot of that to train not only patients, but also to do doctor communication skill interventions. So for training, I think it has huge possibilities.
Another question from the same person. Do you expect more actively engaged patients, more questions, or will better prepared patients ask less questions, so less actively engaged patients?
Okay, so that is that's a really good question, and it's very thoughtful. Because why am I asking a question? Because I don't know, and so I'm asking a question. If I've gone and done some research, I now know some things, and I don't need to ask a question. That's true. On the other hand, am I asking questions because I want to know more, or I want to know more in depth, or something? So actually going and going online and getting more health information may actually then spur my question asking into a lot of different kinds of things based upon what I learned. So one of the things that we do in our research is it's hard for us to distinguish the quality of one question relative to another question. So we have to use a quantitative measure of how often did they ask a question. What that does is it puts the physician in a position to do the other second pair part. All the sociolinguistic people in here would know the second pair part of being able to fulfill the answer to the question, an obligation for something that is an answer. So these are powerful communication tactics because of the expectations it puts on our partner to respond. So to answer that question, that ends up being something that requires a bit more in-depth, probably largely qualitative work to get in there and think about the nature of me asking questions with being informed versus me asking questions when I'm not informed. Qualitatively, are those questions different? They could well be, and that's a really, really, really good question.
I have a comment from Carrie Stevens. Thank you, Dr. Street. I'm also impressed with the questions people asked. This is important work. Another one from Suleiman. Health information is critical. People can die because of use of bad medical information. What simple credibility assessment tool can we provide and spread the word? How can we educate people?
So, I don't do a lot of the, the kind of, being a gatekeeper to health information and how do we evaluate some of its value versus some of its not. But I think there is something to be said about you just don't get information in isolation from other sources. So if you go onto the internet to look up something, you're going to get a lot of the same kinds of responses from a lot of different folks, right? In terms of like things that contribute to, hypertension or CHF or whatever it was that you can. There's a lot of similarity that you'll see. When you get the way out in the wild kind of response says, oh no, you don't have to do any of that. It's something, something, something. Then the credibility then would be the preponderance of the evidence about I found this one thing, but in doing my research I found all of these other kinds of things as well. So I think the best way that people are going to be able to address that issue is they're going to have to focus on specific kinds of clinical conditions. And so if you are a doctor of a certain sort, a certain specialty or something like that, then one of the things that you could do would be to focus on the kinds of information you find on the internet related to this particular clinical problem and what kinds of either inoculation or fact-checking can we do so that we help get people to be involved enough to kind of check what we think would be with regard to whether that information is accurate or not. It's real hard to say one across the board kind of thing. I would think that would best be as it relates to a particular clinical condition.
I have a question. Can I ask a question? Yeah.
Yes.
I'm an undergraduate academic advisor, students where they are. And of course, for us right now, email is the most, I'm reluctant to put in an email. Sorry, you're not graduating, those kinds of things. And my question to you is, at what point, or is there a point that a doctor or a caregiver, whoever it is, looks at whatever the information is or what the patient is asking for and so forth, thinking, there's no way I can explain this in this format. How can I get them to come in without saying, come in immediately, or something that is alarming? And, are they trained to use these types of technology to where it's obviously it's a protected space, just as we have. There are certain things we cannot email for rules, all that kind of stuff. But I'm just thinking, there are things that I read knowing I cannot put this in writing, not for that reason, but because I know the student won't understand in the terms I would use. And so at what point does a doctor or whoever say, I'd really like to have this as a face-to-face conversation with you, or something, so I can get the immediate feedback, so I can see on your face that you understand. Even if that was students, I look at their faces going, they are not understanding this at all.
Right. So, so the question is, how can you, when you're dealing with particularly sensitive and perhaps bad news kinds of information with regard to patients, how can you pick the right medium or the means by which you can communicate that information? Okay, so this is something that there are kind of two approaches that I would say to address that. One is for those people who feel it is important to accommodate patient preferences, they then ask them, in what form would you like to get this information? And so the patient may say X, and so they say, okay, when we find out, we will give you X. Now, that is, on the surface, we're accommodating the patient's interests and their preferences and things like that. But, patients may be getting news that they've never had before. And so now what? So they haven't thought through what the consequences are, things like that. And there could be some unintended consequences associated by simply saying, before you get the news, in what way do you want the news, so that after you get the news, you may have now changed your mind and want the news somewhere else. Preferences change. They can change. Some are stable, some can change. So that's one approach that you could do. The other way to preempt that is to say, all our consultations on this topic, on bringing this news, is a face-to-face consultation. And therefore, we just wipe it out. So we may have it, and that's all? That's all. Okay, versus we have this and something. I think that would be the best way to regulate that. So, I can see advantages of both ways, I know I almost would rather have an email, than have to be in an awkward situation with my feelings with other people, You lose control that way. That's one of the worst things you can do, is lose control. But then again, I don't know. But then again, there are other people that would really want that to be a face-to-face. My wife, who is also an academic advisor and an undergraduate, directs our undergraduate program, would be just the opposite. She would want to have a face-to-face, conversation about those things. So that would be the two things that come to mind that I've heard people talk about.
AT&T support person or my credit card person or whatever. And I really like that as a method because I don't like waiting through the wait time on a phone.
Right,
And
right,
so
right.
I don't want to go down to the AT&T store to tell my story about my box that's sitting in my house. And so do you find that some providers now are preferring certain methods that then perhaps even discourage patients from coming to see them?
Okay, so the question is, do some doctors prefer using the technology as kind of an alternative to coming and seeing them, Or in the first part of that question, I thought what you were going with was if they're uncomfortable talking about a certain thing, they'd rather use the technology to do it rather than doing a face-to-face. All right, so I'm going to answer what I said last, which was the first thing that you brought up with first. So I see being the uncomfortable part is the most important part, whether or not technology is involved. So technology is a component to the extent that it can be part of what is a means to try to deal with this kind of thing. One of the most difficult things to work with in doctor-patient communication is the communication of prognostic information. It is just really difficult because there's not a lot of exact science to go with some of that. Patients want hope. You know, they want you to be honest with them, but be hopeful, you know, so you're put in that thing. Doctors have relationships with patients and they make assumptions about, I can't tell them this way, that'll really upset them, you know, and well, you just got to be real direct. You just got to tell them, you know, just give them the facts. And then that can be bad. And so it's just really, really hard to have prognostic conversations, particularly when prognosis is not very good. So in that particular case, might a person who really is uncomfortable with those conversations, really doesn't want to do it, is it kind of an avoidance of the immediacy of face-to-face to just shove it off on a technological avenue for doing something like that. And then the other part is whether or not doctors would rather have online alternatives rather than coming in face-to-face. I would think doctors would certainly, many of them would say, if you're going to come and see me, there ought to be a reason why you're seeing me. I know for sure patients, many of them love video conference opportunities because they don't have to travel, and particularly when they're doing follow-up. So like at the VA, when you talk about the VA and you have your regional clinics out there, you know, why do you have to go to the major medical center for something to follow up when you can stay 90 miles away in your place and just have a video conference? And wouldn't that be nice if you could even do that from your house? So I think the patients tend to be generally, many of them are very supportive of being able to have alternative or have options for how you can have these kinds of interactions. So that answers that second part of the question. But that first part that's a really hard one, you know, to do in terms of doctors and how they deal with their own anxiety that they have and feelings for a patient, and kind of the empathy they may have patients, particularly if they've been working with them for a while, in terms of the discomfort associated with letting people know something not good is happening.
Rick, we're just about out of time for
Okay,
questions.
very good.
I want to thank you very much and thank our local
Yeah,
audience.
thank all of you. That was great.
As well as our national audience.
69 viewers.
Pardon me?
69 viewers.
All
We
right.
had 69 live viewers, and of course, many other hundreds can watch this recorded presentation later on this afternoon. Tomorrow,
Thank you.
we're very privileged to have Dr. Kim Nazi of the Veterans Administration and the Office of Consumer and Veterans Health Informatics. She'll be talking about myths and legends regarding patient access to their electronic health records. That's at noon Central Time tomorrow. Once again, thanks very much,
All right,
Rick.
thank
and
you,
thanks
John.
everybody here.
Yeah, thank you. Thank you all.
Thank you.
Yeah, okay.
Good job.
Oh,
Really
good, thanks.
job.
Thanks.